doctors. So welcome to the internship program that is conducted by Doc Tutorials. So in this session, I would be discussing few key points that you have to take care while taking care of a delivery in the labor room that will help you during your internship as well. So in this, you know that in the labor, you have first stage of labor where the cervical dilatation starts and first stage is still 10 centimeters. Next, you have the second stage of labor where there is descent of the fetal head and expulsion of the baby. Next, you have the third stage where there is expulsion of the placenta. So when a patient is in labor, you will be asked to check for how the cervix is dilating, how the labor is progressing. So first, let's see how you are going to assess the cervical dilatation and factors associated with it. So when you check for cervical dilatation, it's not just the dilatation that you should do when you do a per-vaginal examination. The factors that you should check in a per-vaginal examination include dilatation, effacement, station of the baby's head, the consistency of the cervix, and also the position of the cervix. So first, let's go into the most important aspect, which is the dilatation of the cervix. So when you do a per-vaginal examination, this is something that you would feel this is a representation of the same. This is the lower part of uterus and the cervix. When you do PV, you can assess, as I told you, you assess for the dilatation, effacement, station, consistency, and the position of cervix. First, let's have a look at the dilatation of cervix. So here, when you see that this opening, which is known as the external os, is closed. If you see that it's completely closed, you will tell that the dilatation, it's a closed cervix. Next thing what you see here, you can insert a finger, but it is tight. This one finger tight, this is your 1 centimeter dilated cervix. Gradually, it keeps on dilating. In the next one, you can see that you can insert 2 fingers, but it is tight. This is your 2 centimeter dilated cervix. And in the next one, you will appreciate you can dilate 2 fingers, or you can put in 2 fingers, and there is loose, 2 finger loose, which is equivalent to your 3 centimeters. It is equivalent to 3 centimeter. Further on, it goes on to 4 centimeter. So the best thing that you can do practically is that you can just take a scale and measure how much is your 1 centimeter. Suppose you are having a chubby finger or a very thin finger, it might slightly differ. But as a rule of dictum, whenever you feel os is completely closed, that is closed cervix, when you can put 1 finger, it is tight, it is 1 centimeter. If you can put 2 fingers, it is tight, that is equivalent to 2 centimeter. Slightly loose 2 fingers is 3 centimeter. Then further on, it goes on to 4, 5, 6, and finally you have the 10 centimeter, which is known as the fully dilated cervix, which is 10 centimeters. Okay, so my best tip for that would be just take a scale and see how it is going so that you get a general assessment when you do the PV as well. So this is what usually interns or anyone who is doing PV reports as well, right? When we ask what is the PV of the patient, they just tell that she's fully, or she's 3 centimeter, she's 4 centimeter. But dilatation is not the only component that you are going to measure while doing a PV. What are the other things? You have to check for effacement. You have to check for effacement. Let's have a look at the effacement. Effacement refers to the taking up of the cervix, or in simple terms, it tells you how thin and soft the cervix is. So here you have a big long cervix, which is normally seen, which is known as an uneffaced cervix. So let's compare it with the next one. So here you are seeing that the length of the cervix has considerably reduced and the thickness, it has also become more thin. This is something which is equivalent to a 40% effaced cervix. So again, it's a comparative thing. If you have a look at the next one, you will see that again the cervical length is less and then it is very more thin as compared to the previous one, which is nearly equivalent to 50% effaced. And if you have a look at this one, you will see that there is no cervix which is felt. It is very, very thin, which is nearly 100% effaced cervix. So the problem with this effacement is that it is very subjective. That is why the initial Bishop score, which I have provided here, use the effacement as a parameter, and in the correct modified Bishop score, this effacement is replaced with cervical length, which is much easier, right? Cervical length means you are going to measure how much is the length of the cervix, whether it is 4 centimeter, 3 centimeter, 2 centimeter, and so on. So in the current modified Bishop score, this effacement is replaced with your cervical length. So till now we have seen two parameters, that is first was dilatation, next is effacement. Next, moving on to the consistency of cervix. So cervical consistency is defined as either firm consistency, mid consistency, or soft consistency. So in medicine, we say that something is soft when it is resembling the consistency of your lips. If it is resembling the consistency of your tip of nose, that is your firm consistency, and the consistency that you feel at the tip of forehead, that is your hard consistency. So soft, firm, and hard consistency. So in cervix, we have just three types of consistency, that is either soft, firm consistency, or something in between, which is known as mid consistency. So you are going to report that as well, whether you feel a soft cervix, mid consistency cervix, or a firm cervix. Next, moving on to the position of the cervix. So in pervaginal examination, the position of cervix is defined as posterior, mid position, and anterior. For you to understand it more, let's have a look at the same in the mannequin. So for you to visualize it better, I have removed the perineal surface from here. So initially when you do the PV, you feel that the cervix is posterior, and as the labor progresses, it moves more anteriorly. Next you have mid position, and finally the anterior cervix. So initially you have posterior cervix, which is more unfavorable, then you have mid position, and finally anterior type of cervix. So the final component is station of the fetal head. The station of fetal head is determined in respect to your ischial spine. If you see that the head is 1 centimeter above ischial spine, you will write it as -1, and if it is 2 centimeter above, you will write it as -2. So it goes on like that, -1, -2, -3, -4, -5. If it is 1 centimeter below ischial spine, you will write it as +1, +1, +2, +3, +4, and +5. How will you determine this ischial spine? When you do a PV and look and feel for the lateral wall of the pelvis, you can feel a prominent structure, which is known as your ischial spine. So again, recapping, the 5 components of the Bishop score include the position, dilatation, effacement, station, and consistency. In the modified Bishop score, this effacement has been replaced with cervical length. When the patient comes to you in labor, you do a sterile pervaginal examination. After putting the gloves, then you are going to clean, drape the perineum. Insert your 2 fingers gently by retracting the labia. Insert your 2 fingers and then you will assess for the dilatation of cervix, the effacement, station, position, and consistency. So don't worry, we would be going into the components of each of this one by one. So when you see that in your labor, the fetal head is distending the perineum and the head does not recede back in between contraction. This is known as crowning. At the time of crowning, the perineum is very thin, and it is at this point that you put the episiotomy. So this angled scissor which you see here is known as episiotomy scissors. This has a sharp surface and a blunt surface. It is the blunt surface that is inserted into the perineum to cut the perineum. So students, please note that though you see episiotomy very regularly in most of the cases where the patient is in labor, episiotomy is not routinely recommended. So episiotomy should be done only when indicated. This is as per the WHO guidelines. Routine episiotomy is not indicated. So how to put the episiotomy? We give the cut in such a way that it is at 60 degree to the perineum. So students often have the doubt that it is 45 degree. When you have a stretched perineum where the baby is distending the head, the angle is 60 degrees. So you're going to give a cut through the perineum and the angle here is going to be 60 degrees. During the time when the baby is crowning and the baby is descending, you have to provide a perineal support. This is important so that the tear does not extend towards your rectum. So as to prevent perineal tear, you give a perineal support. So use your one arm to support just below perineum, and the other hand is used to flex the fetal head. So once the baby's head is more outside, so comparatively now it's more inner side. So as it comes more below, you have to flex the fetal head so that the tear does not extend towards your urethra, and other hand is used to support your perineum. Let me again show you once again after removing this part of perineum. As we discussed, you have to keep one hand so as to support the perineum, and the other fingers are kept so as to flex the fetal head. Either you can flex the fetal head like this, or with your two fingers, you flex your fetal head. Why? The baby's head delivers by extension. You want a very controlled extension so that there is no tear extending into urethra, and you want a steady support on the perineum so that the tear does not extend to rectum. This maneuver where you give a perineal guard and do a control extension by flexing the fetal head, this is known as your Ridgens maneuver. So again, it's an image-based question as well. They will give you such an image where you are flexing the fetal head and giving perineal support. This is your Ridgens maneuver. So you can see the fetal head which is descending. So you give the support. You are going to keep the fetal head flexed. Yes. And along with that, you see how beautifully the baby is externally rotating and delivering. So it's a very tight mannequin which is there. So still I hope you can appreciate how it is rotating. You need not rotate the baby. Baby will rotate on its own. You just have to give the perineal support and keep the fetal head flexed. Usually the baby will kiss the mother's right thigh and deliver. That's what we say poetically. So you can see the baby's head which is facing towards the mother's thigh and delivering. Next you have the delivery of the shoulder. At this point of delivery of shoulder, either you can ask your assistant to give a perineal support, or you can deliver by using one hand. As a beginner, it would be better. You can ask your assistant to give a perineal support. You ask the assistant to give perineal support and you put your two fingers on either sides of the fetal head. You put your fingers and you are going to give a downward traction where you see the delivery of anterior shoulder, then an upward traction where you see the delivery of posterior shoulder, and then you can easily deliver out the baby. After the delivery, you keep the baby over the maternal abdomen. With this, we come to the end of the second stage where you have delivered the baby as well. Next comes the third stage. So now the baby has delivered. Now your work is not done. You still have to deliver out the placenta. How will you do the delivery of placenta? Will you just pull out the cord and deliver the placenta? Never. You have to initially wait for 1 to 3 minutes before you clamp and cut the cord. So even after the baby is delivered, you will not immediately hurry, which often happens in the labor room. As soon as baby is delivered, there is a lot of rush. Everyone is jumping to just cut the cord. That should not happen. You should wait for at least 1 to 3 minutes to clamp and cut the cord. The main advantage is that at this time, the baby's neonatal circulation is getting established, more blood is going to the baby, the risk of anemia decreases. So how long will you wait? You will wait for 1 to 3 minutes. This is known as delayed cord clamping. You will do a delayed cord clamping, and you will deliver the placenta by doing a controlled cord traction. Again, after cutting the cord as well, yes, you will not just pull out the umbilical cord. What will happen if you pull out either the cord can get torn from there, which is known as cord avulsion, or your uterus can invert and come outside, leading to a complication that is uterine inversion. So you will wait to see the placental separation signs. So you are going to give a control cord traction where you will see that there is this lengthening of umbilical cord which is happening. Then you can see the gush of blood which is coming outside. And when you palpate the uterus, you feel that the uterus becomes firm, globular at this point of time. So you give a gentle cord traction that is known as control cord traction. You have to give a suprapubic pressure. You are going to give a pressure over the uterus upwards so that the uterus does not invert and come outside. So we are going to give a control cord traction with a slight traction over the uterus so that the uterus does not invert and come outside. This method of placental delivery is known as branded Andrews technique. Again, an image-based question as well for your PG exams. So this method of delivery where you give a controlled cord traction with a counter traction over the uterus, this is known as branded Andrews technique. So you give controlled cord traction so you can see the placenta delivery. So hold the placenta, then you will rotate the placenta and deliver it. The advantage is that all the membranes which are attached along with the placenta will deliver in toto. After the delivery, the placenta should immediately not go into the dustbin. You have to still examine the placenta. You have to see whether this placenta is complete or not. This part of the placenta, which you see, is known as maternal surface. This maternal surface have the cotyledons. So you will examine by putting it in your hand whether all the cotyledons are complete. You are going to look at the edge of the placenta. This edge of the placenta, you will specifically look to see any interconnecting blood vessels. So if you see that there is some blood vessels which is connecting and pointed, showing there, it is suggestive of a additional lobe which is there. So again, in succenturiate lobe of placenta, where there is an additional lobe, there can be this interconnecting blood vessels. So if you see that there is a bulging opening blood vessel which is there, always think about an additional succenturiate lobe. You will again have a look at the uterus, whether to see are there any left out lobes inside the uterus. So you had a look at the maternal surface, which has the cotyledons, then at the edge of placenta, then also at the fetal surface to see if the membranes are complete. Once you see that the placenta you have delivered in toto, then you can discard the placenta. So again, don't be in a hurry to discard the placenta. Don't be in a hurry to clamp the cord. Don't be in a hurry to pull out the cord and deliver the placenta. You are going to do a delayed cord clamping where you wait for 1 to 3 minutes. You are going to do a controlled cord traction with a counter traction over the uterus known as branded Andrews technique. And even after delivery, you are going to examine the placenta to see whether it is delivered in toto. These are the things that you did in the third stage. But this is what you did. The active management of third stage of labor, the first and the most important step is giving the patient oxytocin. So immediately by this time, the nurse would have given the oxytocin. Again, you should know the dose of oxytocin. You give 10 units intramuscular injection immediately after delivery of baby. So this oxytocin is the most important step in the active management of third stage of labor, which again helps to prevent the postpartum hemorrhage. So oxytocin, next was delivery of placenta. Third thing is you will assess the tone of the uterus. You are going to put your hand over the uterus, see what is the tone of the uterus. If you see that the tone of uterus is decreased, you will start massaging the uterus. This is known as uterine massage. So when you see the tone of uterus is decreased, you do the uterine massage so that the uterus contracts and the risk of bleeding reduces. Previously, as per the older WHO guidelines, this uterine massage was done for every patient. Uterine massage was a routine part of your active management of third stage of labor. But as of now, they are recommending first you assess the tone. If tone is decreased, then you proceed with the uterine massage. So that was about your third stage. And again, please note that the labor stages does not just end at the third stage. Even after third stage, you have the fourth stage, which is 1 to 2 hours after delivery. So often what happens, once you have delivered the baby, you have delivered the placenta, you are relaxed. You now just leave the patient. Still, patient can have complication at this point of time. You have to vigorously monitor the patient, including you will check for pulse rate, blood pressure, urine, whether she has passed urine, the respiratory rate, SpO2 of the patient. You vigorously monitor this patient for at least the next 1-2 hours so that you can avoid complication, which is known as your fourth stage of labor. So let's have a look at few of the complications which you can manage well as an intern, such as your shoulder dystocia or postpartum hemorrhage, which are obstetric emergencies. And it is very crucial that you are aware of the initial steps that you are going to take to manage such situations. So first, let's have a look at shoulder dystocia. In shoulder dystocia, there is difficulty in delivery of the shoulder after delivery of the fetal head. And the interval that you see between the delivery of fetal head and fetal shoulder is more than 60 seconds. So in this scenario, as you see here, the anterior shoulder is stuck behind the pubic symphysis. And there is a sign that is attributed here as well, known as turtle sign. Turtle sign means the head is receding back into the perineum after coming outside. This is the turtle sign. Just one liner which you can utilize here as well. So suppose you see a delivery, the head has delivered and the shoulder is not coming out. You try and the shoulder is not coming up. First, you should know what not to do. Do not try to give excessive pressure and pull out the baby. You will not try to just give a traction and pull out the baby. What will happen? There can be injury to the nerves that are there, causing Erb's palsy, brachial plexus complications. So, do not give traction. Second thing is, you are not going to ask your assistant to give any fundal pressure. So, don't give undue traction. Don't give excessive fundal pressure as well. What will you do? Immediately ask the woman to flex and abduct the leg. So you'll ask the woman to flex and abduct both the legs. Flexion and abduction of leg. This maneuver is known as Mac-Roberts maneuver. Very important. Immediately ask the patient to flex and abduct the leg completely over the abdomen, known as Mac-Roberts maneuver. Again, you are going to give a simple, gentle traction, try to deliver the head. If still it is not possible, you ask your assistant to give suprapubic pressure. So, as the assistant just will be giving the suprapubic pressure just above the pubic symphysis. Students, please note, this is the suprapubic pressure. It is not the fundal pressure that you give from here. This is the suprapubic pressure. So, as you give suprapubic pressure, the bisacromial diameter, that is between the shoulder, decreases and you can deliver out the baby. Yes. So what you saw here right now was Mac-Roberts maneuver and suprapubic pressure. So whenever in labor room you see that there is difficulty in delivery of shoulders after delivery of head, suspect shoulder dystocia, you have to immediately call for help, then proceed with this procedure, that is Mac-Roberts maneuver, where you ask the woman to flex and abduct the leg, then proceed with the suprapubic pressure. And with these simple maneuvers, which are known as the first line maneuvers, 90% of cases of shoulder dystocia will get corrected just by this. You need not even go to the complex maneuvers such as internal rotation maneuvers. You have next the internal rotation maneuvers like the woodcock screw maneuver, Rubin's maneuver, delivery of posterior arm, finally destructive maneuvers. All these are not routinely indicated. With this just two maneuvers, 90% of cases of shoulder dystocia is corrected, and it is very important that you are aware of these maneuvers. Next, let's discuss briefly about postpartum hemorrhage. So, as you know, postpartum hemorrhage is the most common cause of maternal mortality. Most common cause of maternal mortality, again, you should be able to recognize this and you should be able to promptly take the correct intervention. So, in a vaginal delivery, if you see that the bleeding is more than 500 ml, or in a case of cesarean section, you see that bleeding is more than 1000 ml, or irrespective of route of delivery, bleeding is more than 1000 ml, you will think about this postpartum hemorrhage, immediately alert your team. So the first thing in any obstetric emergency is call for help. Okay, so you call for help, you call for the senior obstetrician who is there, you're going to call for the help from the interns who is there with you, the nurse. So the whole team has to be alerted immediately. Next, you will ask whoever is there assisting you to put 2 wide bore IV cannulas. So 2 wide bore IV cannulas are put. So the main advantage is that at the same time you can take the blood and also give or start the patient on IV fluids. The preferred fluids are your crystalloids such as normal saline and ringer lactate, or even DNS can be used. So you rapidly infuse the patient with fluids, and once the blood is available, blood transfusion can be given. What will you do at this point of time? So you are at the foot end of the patient. What can you do at this point of time? Immediately start the uterine massage. So I taught you, along with active management of third stage of labor, you will go for uterine massage if the tone of the uterus is decreased. Here, in a scenario where the patient is having postpartum hemorrhage, you will immediately go for uterine massage. So you do the uterine massage. At the same time, there is a small error that most of the interns make, that is, you forget to empty the bladder. So suppose you have a full bladder and the uterus is there just behind that. Now the uterus will not contract properly. So don't forget this step. You have to empty the bladder. So you drain the bladder, empty the bladder. Again, this will help you to do a better uterine massage. This will help the uterus to contract better as well. So uterine massage and emptying the bladder. Next comes your medications. The drug of choice or the best drug that you can give is oxytocin. So you will start an infusion of oxytocin. You can put in the saline bottle, whichever is there, you can put from 20 to up till 40 ml of oxytocin, and it should go at a rate of 125 ml per hour. So you will put the oxytocin, give oxytocin infusion. Suppose bleeding is still not controlled, uterus is still relaxed, the next medicine that you will consider is methyl ergometrin, which comes under the name methergin. So you will give methergin. The dose of methergin that is given is 0.2 milligram, which is usually given as an intramuscular injection. So you give methergin 0.2 milligram intramuscular injection. Then again maximum 5 doses can be given to the patient. Very, very important. Whenever you give methergin, always rule out whether the patient has hypertension, whether the patient has heart disease. Hypertension, heart disease, methergin is absolutely contraindicated. Suppose you have a patient who is Rh negative pregnancy. Even in Rh negative non-sensitized women, we avoid methergin because of the increased risk of feto-maternal hemorrhage and sensitization to happen. So important points that you will remember: methergin commonly given as intramuscular, maximum 5 dose, absolutely contraindicated in hypertension, heart disease as well as Rh negative pregnancy. Next drug that you will remember is carboprost. Carboprost only route available is intramuscular injection. Even you can directly inject into the uterine muscle. Suppose you have a cesarean section, uterus is right there in front of you. You can directly put this injection into the uterine muscle, which is known as intramyometrial route. The dose is 250 microgram intramuscular injection, total of 8 doses. This was a previous year question as well. They asked what is the total dose of carboprost that you will give. That is 250 into 8 is 2000 microgram. 2000 microgram means 2 milligram. So the maximum dose that you will give is 2 milligram. And again, students, please note, patient has bronchial asthma. Carboprost is absolutely contraindicated. So you should be aware of these contraindication. Only if you are aware, you can ask about these risk factors or this pre-existing condition that the mother is having, then accordingly decide the medication. Finally, you have misoprostol. Misoprostol is usually available as tablets. You can give the tablets in the form of oral route, sublingual route, and commonly we give as rectal route. So I do know that there is a vaginal route, but why don't we prefer this vaginal route in PPH? Already the patient is having so much bleeding. There is this excessive bleeding to the genital tract. If we put in a per vaginal route of tablets as well, that is just going to get washed away. So there is no role of a vaginal route of misoprostol for your postpartum hemorrhage. You can give as rectal, oral, or even sublingual routes are available. Usually for the treatment of PPH, we give a dose of 800 to 1000 microgram is given to the patient. And often in the labor rooms, in the operation theatres, you will see a drug known as tranexamic acid. Tranexamic acid can be given 500 milligram to 1000 milligram. But it is not a standalone drug. Okay, it's usually given as an adjuvant medicine along with the other treatments. Suppose you have already given oxytocin, still as an adjuvant, you can add in some tranexamic acid. So again, just recapping the drugs that we discussed, you have oxytocin, methergin, absolutely contraindicated in hypertension and heart disease. Next, you have carboprost, absolutely contraindicated in bronchial asthma. Finally, you have misoprostol and tranexamic acid as an adjuvant. If still it is not effective, we have lot of interventions like the mechanical methods are there, and finally the surgical methods. But at least the medical method has to be thorough for you. So suppose you have a patient who is bleeding massively and you have to manage the scenario, and there is so much time for the help to arrive, you should be able to manage that case effectively. Again, students, PPH is the most common cause of mortality in the mother. So every minute, every time that that you lose, you are putting the woman at risk. There is risk of death for the mother. So these simple measures, these simple medicines you should be aware of. Feel that we can feel the anal opening and the two sacral bones which is there. You will suspect a breech presentation which is there. Suppose it is a breech baby. Let's see how you are going to perform an assisted breech vaginal delivery. The main core technique of assisted breech vaginal delivery, initially you are going to do no touch technique. Do not try to pull the baby initially itself. Let the nature do its work. Let the uterine contraction push the baby. So you will see that gradually the baby is delivering. Here you can see that the legs are extended. So in Pinard's maneuver, you apply pressure over the popliteal fossa. So you take your two fingers, run it parallel towards the femur. Then you are going to give a flexion pressure. You will flex and abduct the leg so that you can deliver out the leg. So initially you have delivered one leg and then again you are going to give a pressure over the popliteal fossa, deliver out the other leg. This is your Pinard's maneuver. As well, you are going to hold the baby very gently at the level of your pelvic girdle. Again, you don't want to push, hold it firmly here. You have the susceptible abdominal organs which you can injure. You don't want to hold at the thorax. You will hold at the pelvic girdle like this. So again, after the delivery, next you can see that again the hands are being delivered. The hands are extended. This extended hands cannot deliver. So what will you do? You will proceed with Lawsett's maneuver. The arms are extended. You are going to rotate the baby so that one arm is visible or one shoulder is visible. Then you insert your hand. You are going to sweep the arm across the baby's abdomen. So you have one arm delivered. Again, similarly, you will rotate it to the other side. Put in your fingers. You are going to sweep the arm across the maternal abdomen. This maneuver where you rotate the baby through 180 degree, this is known as your Lawsett's maneuver. You have delivered the legs, you have delivered the arm, next comes the aftercoming head. Again, you will not proceed directly with the delivery of aftercoming head. You will wait till you see the nape of the neck. You can initially allow the baby to hang by its weight. So as to deliver the head, we have three specialized maneuvers. So as you know, the weight of the body is less as compared to the head. You require special techniques so as to deliver the aftercoming head. So the first you have Burn Marshall technique. In Burn Marshall technique, you are going to hold at the feet of the baby. You will hold the feet of the baby, give a traction. You can ask the assistant to support the perineum and give a gentle suprapubic pressure, and you are going to swing the baby in an arc across the maternal abdomen. This technique is your Burn Marshall technique. So in Burn Marshall, hold the feet, give a small traction and swing it in an arc across the maternal abdomen. You will swing it in an arc across the maternal abdomen, which is your Burn Marshall technique. Next, you have Mauricio smelly wheat technique. In Mauricio smelly wheat technique, your one hand is supporting the baby's body. On the malar eminence like this. Okay, two fingers on malar eminence. Your hand is supporting the fetal weight, and then your other hand is kept over the nape of neck. And one finger on nape of neck. And with this technique, you are going to give a traction and you will deliver the baby's head out. Like twisting like this, where there is two fingers on either side of malar eminence and the other hand is kept like this besides the neck and one finger over the nape of neck. You will think about Mauricio smelly wheat technique. So in Mauricio smelly wheat technique, you are going to give a flexion over the malar eminence and you will do a controlled traction of the head so as to deliver out the fetal head. The final maneuver is to apply a forceps. The forceps that you use to deliver the fetal head is known as Piper's forceps. So the Piper's forceps blades are applied on either side of the fetal head, and with this forceps you can deliver out the baby as well. To deliver the aftercoming head include the Mauricio smelly wheat technique, where you are going to turn the baby in an arc across maternal abdomen. Next, you have Mauritius smelly wig technique. And the third one is using a forceps on the fetal head known as the Piper's forceps. So students often find it difficult to grasp the concept of the presenting part. So which part is presenting in the fetus depends on the attitude of the baby. So the attitude of the baby can be fully flexed. So if we have a baby who is fully flexed, the presenting part which is there is this part which is known as vertex of the baby. So it is vertex. So let's have a look at the vertex. So again in vertex, you are going to see this lambdoid suture. And in between you have a triangular shaped small frontanel which is known as your posterior frontanel. So if you can feel this lambdoid suture and this posterior frontanel, you are basically dealing with a vertex presentation. So this happens when the baby's head is fully flexed. Now, what will happen if the baby's head is fully extended? Suppose baby's fetal head is fully extended, this part of the baby is presenting. That is the face of the baby, which is known as face as the presenting part, commonly described as face presentation. So if you have a look at the face, the most prominent part in the face is this. That is mentum, which is known as the denominator. So in a fully extended head, you have face as the presenting part with mentum as the denominator. What is the use of this mentum? Mentum will help you to assess for the position of the baby. If this mentum is towards the pubic symphysis, I will call it as mento anterior. If this mentum is towards the sacral promontory, I will call it as mento posterior. So when it is fully extended, suppose here you have a pelvis, the face is the presenting part. If mentum is anterior, it is mento anterior. Mentum is posterior, it is mento posterior. So this is about your face. So what all can you feel in face? You can feel mentum and even you can feel this ridge above the eyes, which is known as supraorbital ridge. Now with the supraorbital ridge comes the next type of presenting part. Suppose it is partially extended. In a partially extended head, this part of the baby is presenting. This part is known as brow presentation. So here you have face, next is brow, and finally you have the vertex. So here you have face, next is brow, and finally you have the vertex. So if this part which is brow is presenting, in brow as the presenting part, you can feel for the supraorbital ridge and also the anterior frontanel. So again, let me show you in the baby itself. So if this part that is brow is presenting, you can feel the supraorbital ridge and this diamond shaped frontanel. This diamond shaped frontanel is known as anterior frontanel. Question gives you supraorbital ridge and anterior frontanel is felt. You are basically dealing with brow as the presenting part. When brow is the presenting part, the diameter that will engage, if so, in a deflexed head, brow as the presenting part, the diameter that engage is this diameter, which is from the mentum to vertex. Mento-vertical diameter. This mento-vertical diameter is 14 centimeter and there is no one single diameter in the pelvis which is beyond 13 centimeter. So whenever you have brow, it is mento-vertical which is 14 centimeter. Always the delivery has to be through cesarean section. Whereas in vertex presentation, where the baby's head is fully flexed, vertex is presenting and the diameter that present is just below occiput, subocciput, till the anterior frontanel which is known as bregma. So this is the diameter that is suboccipitobregmatic. In case of vertex, it is suboccipitobregmatic. In case of face, it is submento, just below mentum to bregma, submentobregmatic. This suboccipitobregmatic and submentobregmatic is 9.5 centimeters. So you know that when a baby is in vertex as presenting part, baby can undergo vaginal delivery. So similarly, even when the baby is in face as presenting part, face is not equal to cesarean section. Even when the baby's face is presenting, if the mentum is anterior, you can go for a vaginal delivery. So don't mark face as always cesarean. Face can undergo a vaginal delivery if it is mentum anterior. Mentum is posterior, always cesarean section. So bro means always cesarean section because you have very large diameter, very large anteroposterior diameter, which is 14 centimeter. When it is vertex, again you can attempt a vaginal delivery. In face, it depends on mentum anterior or mentum posterior. If mentum is anterior, go for vaginal delivery. Mentum posterior, always it is cesarean section.